Okay, sorry. Okay, so UBM is extremely valuable imaging technique for detailed examination of the anterior segment. When we're talking about structures like ciliary body, zonules, anterior chamber angle, iris, and especially the interrelationship between these structures. So the UBM is an extremely important tool. And this importance becomes all the more when the cornea is hazy and the gonioscopy cannot be done. So UBM, it not only tells us that how the angle is, whether it is an open angle or an closed angle, but at the same time, it also allows us to see the interrelationship between these structures. So, and also the edge of UBM over ASOCT being that it allows visualization of the structures behind the iris also. So when we talk about the structures in UBM, as Dr. Talveer has already mentioned, scleral spur remains to be the most important landmark, which can be easily identified where these radiolucent shadows of the cornea merge with the radio-opaque shadows of the sclera. So this here where we mark is the scleral spur. So what are the various measurements that we can take in on UBM? One is being the angle opening distance. So how do we measure that? So 500 microns anterior to the scleral spur, we draw perpendicular on the iris, and this line, this distance is the angle opening distance. Then talking about the trabecular iris angle. So this angle is with its apex at the iris recess and the 2 points crossing the points of the angle opening distance. Third important measurement can be the trabeculociliary processes distance. What is this? So again, 500 microns from the scleral spur, and then draw a straight line bisecting through the iris up to the ciliary processes. Then next come the angle recess area. So 750 microns from the iris, from the scleral spur. Again, we draw perpendicular to the iris. So this triangular area that forms is known as the angle recess area. Next, we move to the other some angle parameters includes the iris thickness along the TCPD line, iris thickness 2 millimeters from the iris recess, and then iris thickness at the level of pupillary margin. Also, we can measure the iris ciliary processes distance and the iris and zonular distances. So these distances are basically, they help us classify the how close is the ciliary body, whether it is anteriorly rotated or not, whether we are looking at an open angle or a closed angle. So we all know that UBM has been characteristically used for angle closure disease, plateau iris, iris cyst, but its utility in open angle glaucoma is less known and less understood. So it's for a fact that the UBM is an important research tool, and the mechanisms of rise in IOP in open angle glaucoma or angle closure glaucoma are continue to evolve, and it is an ever learning process. So for example, in this study, they found that when the choroidal thickness is measured 4 millimeter from the iris root, the anterior choroid, they found that the thickness was higher in both POAG and PACD compared to the healthy controls. So similar to this, UBM will always be an extremely important research tool in better understanding of glaucoma pathogenesis. So the one open angle glaucoma that shows extremely characteristic findings on UBM is the pigment dispersion syndrome, where what we would see is a widely open angle with concave iris configuration, bowing of the iris posteriorly with iridozonular and iridolenticular contact. And again, UBM will also help us to assess in the efficacy of peripheral iridotomy. So here we see when the PI was done, this concavity has been relieved. The reverse pupillary block is now relieved, equalizing the pressure between the anterior and the posterior chamber. However, it is postulated that PI is particularly useful in those cases where the iridozonular contact is significant. So next, coming on to the role of UBM in post-traumatic glaucoma. Again, Dr. Talveer had highlighted this, but I would like to emphasize, especially in cases where there is total hyphema and we plan a surgery, so we need to know beforehand that what are we heading for. So the UBM will help us in identifying iridodialysis. It will help us in identifying angle recession, which can be identified by widening of ciliary body band as the iris, the insertion of the iris on sclera shifts posteriorly. It will also help us to know the extent of blood clots in the anterior chamber. It will help us to see if there is any ciliary body detachment. So here, as we can see, the ciliary body has completely detached from the sclera, and the anterior chamber has become continuous with the supraciliary space. Also, it will help us to assess the zonular status, and we would know beforehand if there is any post-traumatic subluxation of the lens. Moving on to the role of UBM in pseudo-exfoliation. So what we are expecting is a deep anterior chamber, flat iris contour, the deposition of pseudo-exfoliative matter can be seen, but most important role here it would be in cases of PECs where the pupil is small and does not dilate. So the assessment of zonules become difficult. So in these cases, the broken zonules will be visible as small zonular remnants attached to the lens capsule. In pseudophakic glaucoma, so it's not uncommon that we have seen patients after cataract surgery sometimes present with recurrent uveitis or recurrent hyphemas. So the pathology of that can be looked into by UBM. So for example, in this case, we can see the IOL is tilted, and one end of the optic of the lens is rubbing with the posterior surface of the iris, which was giving rise to recurrent uveitis. So these kind of IOL tilts can be picked up by UBM. Also, in cases with pseudophakic bullous keratopathy, where gonioscopy does not allow us, cannot be done, so we can visualize the angle structures with UBM. Coming to post-PK glaucoma, so in these cases, it will help us to see what is the IOL position. It will also help us to determine that what is the kind of glaucoma we are looking at. Is the IOP high only because of peripheral anterior synechia or iridocorneal apposition, or maybe the angles are open and the IOP is high only because of the maybe steroid response. It will also help us in planning of the regrafts, and also it helps glaucoma surgeon to understand and to select the site of filtering surgery so that we can identify a point where there are minimum peripheral anterior synechia. In developmental glaucomas, UBM will show thin iris and poor, small atrophic ciliary body may be seen, especially in case of congenital glaucomas, where it will help us to know what surgery has been done before and what can be the subsequent management. In Sturge-Weber, supraciliary effusions of about 360-degree can be seen with wide open angles, thus proving the hypothesis that the cause of raised IOP is raised episcleral venous pressure. In post-trabeculectomy cases, UBM can help us to see whether the sclerostomy site is open or it is blocked internally by blood clot or by iris. It also helps us in grading of the filtering blebs. So L-type blebs, which are low reflectivity blebs, are usually associated with lower and good control of IOP, whereas these kind of blebs, F-type, are flat blebs, hyper-reflective. They are usually associated with poor control of IOP. Again, in non-penetrating deep sclerectomy, what we can see is the extent of intrascleral lake. We can visualize the trabeculodesmate membrane. Collagen implants that are often used in trabeculectomy or non-penetrating deep sclerectomy, they can also be visualized with UBM and can also, we can also see the resolution or dissolution of these implants with time. When coming to tubes, again, the tubes, if they are occluded internally by iris or by fibrin clots, can be visualized with UBM. So my take-home message is that UBM is an extremely important clinical and research tool for understanding the pathomechanisms in primary and secondary open-angle glaucomas. They're very important for imaging in cases with corneal haze. The extent of iridozonular contact and efficacy of iridotomy in pigment dispersion, assessment of zonular status in PECs with poorly dilating pupils, post-traumatic glaucomas with hyphema, and functional assessment of glaucoma surgeries to look for a cause of rise in IOP post-operatively. Thank you.